Hello, and I welcome you in this presentation. Today we are going to look and learn into the second part of the cranial nerves. And in this division, we are looking at the midbrain division, which will give us cranial nerve number 3, which is the oculomotor nerve, and cranial nerve number 4, which is the trochlear nerve. So let's go into the discussion now. Let us start with the cranial nerve number 3, which is the oculomotor nerve. So there are two basic functions of the oculomotor nerve. Number one, that it controls the movement of the upper eyelid, and then there's a functions within the eye. So the first function, which is very vital, is basically associated with the movement, and that is the general somatic efferent supply. So this will provide the innervation to the skeletal muscles. These branches innervates the levator palpebrae muscles or superioris, which supply the upper eyelid. Then we have the superior rectus, which inserts in the sclera of the eyeball. We are also going to look that the innervation is also supplying the inferior oblique, inferior rectus, and the medial rectus muscle. So this is the skeletal muscle component or general somatic efferent supply of the oculomotor nerve. The second part of the supply or the function is the general visceral efferent, which means that these branches will innervate the sphincter muscles of the pupils, causing the constriction of the pupils, and then it will also supply the ciliary muscles, which causes the accommodation of the lens for the near vision. So in the image that was present in the previous slide and in this slide, so we look at the oculomotor nerve right here. So you look here, different branches of the oculomotor nerve. The first one is right here, the superior rectus muscle that is being supplied. That is a general somatic branch of the oculomotor nerve. Then we have the general visceral efferents, which is the sphincter pupillae muscles right here. And then we have the ciliary muscle right here. So these two are basically going deeper inside the eye. Then we have the inferior oblique muscle and inferior rectus muscle that are also being supplied, including the medial rectus muscle, which is supplied by the oculomotor nerve. In this slide, we're going to look at the general clinical consideration. So what will be the pathologies or the damage to the oculomotor nerve can cause? Number one is the drooping of the eyelid. So that is due to the papillary reflex. Number two, we have the difficulty with the certain eye movements. Usually that will involve the up and down movements. Then we have the difficulty with the lateral rotation of the eye at rest. And finally, we have the dilated pupils or difficulty in focusing. So what are the causes for all these clinical considerations right here? So number one is the compression from the neighboring aneurysmal artery. Again, it is very important. So if there is an artery that is going right here, and if you remember, the aneurysm is a abnormal pouching or abnormal protrusion of the artery supplying the certain areas of the brain. So if the nerve happens to pass there, this pouch is going to impinge on it. So that will cause, in this case, the demyelination. Second one, which is almost universal with the central nervous system, is the tumor. The third cause is the infarction, which is the lack of the blood supply in oculomotor nerve due to its route throughout the central nervous system. It will also pass through the cavernous sinus. So any thrombosis in the cavernous sinus will also cause the impingement of the oculomotor nerve. And finally, we have the infection or meningitis that will also affect the oculomotor nerve and its functions. The next component of the cranial nerves, which are originating from the midbrain, is the trochlear nerve. What are the basic functions? Number one function, it has a general somatic efferent role where it innervates the superior oblique muscle. So almost always one muscle that is supplied by the trochlear nerve. So this muscle is very important and vital for the inferior lateral eye rotation, and this nerve is transmitted through the superior orbital fissure and innervates the superior oblique muscle. So if you look at this nerve is originating from here and coursing through the through the skull, and it will supply here in the superior oblique muscle. So what are the pathologies? Any lesion on this nerve will cause the weakening of the superior oblique muscles. So this will cause the weakened downward and inward gaze, especially in the adducted position. So that is important. The superior oblique muscle is used for reading, and when person is walking down the stairs. So you need to have a downward gaze when you're doing these two things. So any lesion here will cause the affected eye to move or drift upward than the normal eye, or it could be fixed, like it's not moving towards where you basically wanted to focus on. It's not doing it. So hence the patient is going to have a vertical diplopia. So let's look at this image right here. So you see this patient, unfortunately this patient is in a very serious condition, and you see this finger which is being moved from side to side, and this is to basically check the functionality of the trochlear nerve. Two eyes, so when the doctor or the physician like yourself is moving the eye to the left, you see the patient, both eyes are basically able to focus here. But when the physician is moving the finger to the other side, you see the affected eye is basically not moving towards the finger right here, but the normal eye is basically able to fix on this finger. So the affected eye cannot turn in and down due to the superior oblique paralysis, basically due to the damage of the trochlear nerve. So here is, in this slide, we are going to look at the causes of the pathology. This is the final slide, and in the image you can also again look at it, that if the physician finger is right here, present right here, this eye is able to focus on it. This eye is not as much focused like the other eye. So what are the causes of the pathology? Number one is the microvasculopathy, which is due to hypertension, diabetes mellitus, and atherosclerosis. Then of course we have the tumor, and finally we have the aneurysm. We already discussed what will aneurysm do. So this is the artery with the aneurysm, and the nerve is happen to be there, and the aneurysm, when it impinges upon the nerve, in this case it's going to be a trochlear nerve, this will cause the palsy, and this will cause the pathology in the trochlear nerve. So this is the final slide in this presentation. In the next presentation we're going to learn about the cranial nerves that are going to be originating from pons. So please stay put, and I will come back with the next presentation. Thank you so much for your support. Have a great day.